Good afternoon. We're live. It's Thursday, November 5th, 2020, and this is the bi-weekly Healthcare Provider webinar presented by the New York State Department of Health here in Albany. I'm Dr. Elizabeth Dufour, Medical Director in the Division of Epidemiology at the State Department of Health. Joining us this week to update healthcare workers on our latest guidance on COVID-19 is Dr. Marcus Friedrich. Due to the large amount of interest in our weekly COVID guidance updates, we are offering a few different ways to listen to this webinar, live and on demand. The audio and slide deck can be seen on YouTube Live. Point your web browser to coronavirus.health.ny.gov/weekly-healthcare-provider-update. The YouTube Live player is on our healthcare provider's webpage. It's mobile friendly, so you can watch on your smartphone or tablet as well. An on-demand version of the webinar is available via YouTube. Go to coronavirus.health.ny.gov. Click on the providers link at the top of the page, and then click on the weekly healthcare provider update. It's available immediately after the live webinar concludes. So as usual, we'll go through global, national, and New York State updates. We'll review some community mitigation and containment measures and cluster action initiative work, updates to the New York State travel advisory, point of care reporting, test results updates, and some updates on the New York State Department of Health vaccination program. We'll review some resources and go through briefly a couple question and answers. Here's the link on this slide here where the recordings are available immediately thereafter on the New York State Department of Health webpage. In addition to the YouTube Live feature, an on-demand version of our weekly session is available as a podcast. Just search NYSDOH. So now let's take a look at the global picture from the WHO situation reports as of November 1st. Unfortunately, cumulatively, we are now at over 45 million, almost 46 million COVID cases globally, and almost 1.2 million deaths globally reported to the WHO. Notably, over 3.3 million new cases were reported in the past week globally, and over 45,000 new deaths reported over the past week. As you know, on the bottom line in the purple color is the cumulative numbers for the Americas, with over 20,000 confirmed cases from the Americas and over 639,000 deaths. Here on this slide, we see the further acceleration that has been noted of new cases globally, with the most notable acceleration occurring in the European region. That's the green color there. You can see the marked acceleration in the European region, which reported half of the global new cases, over 1.7 million cases, a 22% increase from the previous week. Moreover, the European region also reported a substantial rise in the number of new deaths, with a 46% increase compared to the previous week. Deaths are indicated in the blue line there with the number of deaths on the right-hand axis. And we see here, as compared to our last webinar 2 weeks ago, where although cases were rising, the deaths had remained stable globally, we're now seeing that increase in deaths that is not unexpected following the increase in cases that we're seeing in Europe and globally. Although there are concerning trends noted in Europe, and this has received much attention in the lay press as well, and many are aware, it is notable that Europe and the Americas are now reporting over 17,000 new deaths in the last 7 days and accounting for that uptick. The Southeast Asia region, on the other hand, as you can see in the purple color, has continued to report a decline in new cases and in deaths. Of note, the countries reporting the highest number of cases in the past week remain the same as in the previous 4 weeks: the U.S., India, and France. Again, since the start of the pandemic, 9 countries have reported more than 1 million confirmed cases. Again, here we are, the U.S., India, Brazil, Russia, France, Spain, Argentina, and Colombia, and the U.K. And 5 countries have reported over 40,000 cumulative deaths. Again, the U.S., Brazil, India, Mexico, and the U.K. So as we know, we have a lot of work here to do nationally. Here again, we see the regional graphs presented by the WHO. Please note that the axes are different depending on the region. So you'll see that now the European region and the U.S. region both have on the right-hand side the death numbers with the axes up to 35,000, whereas in Southeast Asia in the upper right corner, it's up to 10,000 with its peak at about 9,000 previously as it has come down since. And so this is notable to see how different regions are facing the pandemic and how efforts may be working. Although the Americas region as a whole reports a 13% rise in cases compared with last week, there were continued declines observed in many countries, particularly in South America. However, again, the U.S., Brazil, and Argentina continue to report the highest number of new cases, with the U.S. reporting a 26% increase this week to over 500,000 new cases, which is 1,650 cases per million population. The European region had seen a 22% increase, as you see in this green figure on the upper left, and a 43% increase in new deaths over the past 7 days compared to prior. And again, new cases and deaths in the Southeast Asia region have continued to decline. This is mainly due to the decline reported in India, which contributes about 80% of the cases in the region. So again, this is for us to be able to learn from other regions and see what those pictures look like. And this is a new figure that was presented over this past week by the WHO that I wanted to share with you all because it really looked at globally age distribution over time. The first figure is looking at cases and age distribution. The next slide will be looking at fatalities. Since the start of the pandemic, increase in the proportion of confirmed cases in the younger population have been observed over time, as you see with a decrease in the percent of the population in the blue color, which is 65 plus, and then an increase proportion in the brown color, which is 25 to 64, and the pink color, which is 15 to 24. Most notably, the proportion of cases among adolescents and young adults, 15 to 24, increased from 4% at the beginning of the epidemic to 14% later on. And those 25 to 64 increased from 50% to 65%. Slight increases were also observed among children 0 to 4 and 5 to 14. Concurrently, we observe obviously a decrease and then stabilization in the proportion of cases among those 65 plus, from 40% in the early stages down to 15% in more recent weeks. Of course, changes in these age distribution trends are likely linked to several factors, including the increased surveillance and access to testing available to younger ages over the latter half of the pandemic and more recently, whereas earlier surveillance and limited testing capacity was often focused on those with severe disease who tended more likely to be elderly hospitalized patients. But it is notable that surveillance and testing capacity, while being expanded and made more accessible to those with mild or no symptoms, additionally, though, other factors could be at play here. The decrease in proportion of elder cases could also, of course, be linked to implementation of infection prevention and control measures and long-term care facilities, and, of course, an increase in transmission in younger ages more recently. And here, this graph from the WHO is looking at fatalities globally. So again, why does this matter? Well, recently many have heard in the lay press that some have proposed that a purposeful transmission of disease among younger age groups would be one way to have a strategy for this virus, aka to obtain a population herd immunity. So one major concern with this approach as a plan or a strategy is a significant challenge in how do you protect the 30 to 40% of the population that is vulnerable or 65 years or older. And that's a real challenge not laid out in a detailed manner in these reports in the lay press. However, a second reason is really that there is actual risk to those who are younger. And this figure is useful in discussing this and viewing this as you discuss with your community members and patients. While absolutely this figure also shows that the risk of severe morbidity and mortality is lower among younger individuals, it is not insignificant. This figure shows the evolution of reported deaths by age and the slow increase in the proportion of reported deaths in those aged 25 to 64, ranging from roughly 10% in the early stages, peaking at about 30% in the summer, and now at about 25%. Reported deaths in those aged 65 and older decreased from close to 90% in the early stages to 75% in the most recent weeks. Again, certainly these data support previous observations that older folks, who often also have comorbidities, remain the most vulnerable to COVID morbidity and mortality. However, 25% of fatalities globally are in this 25 to 64 age group, which is of obvious concern. So now to look at our national picture. Again, this has been quite a bit in the lay press of late, and so some of this is not new to many of you, but just to give some of the numbers. Here we see total cases at now over 9 million nationally, with 26.1 per 100,000 population noted in the last 7 days of cases per 100,000 population, and total deaths cumulatively at 231,988. Just to remind you, what was up on this slide 2 weeks ago for our last webinar, we were at 8.249 million for total cases. So that's a considerable jump over the last 2 weeks of over 1 million. Our rate per 100,000 for cases was at 17.9, and we're now at 26. And deaths were at 220,000. Notably, in the U.S. Yesterday, Wednesday, we see here on this slide, it's a little bit small, but under the cumulative number, you can see the new cases from the day prior. And so this is up to date as of November 4th with the day prior data of November 3rd. CDC reports 88,427 new cases on that date. Notably, according to the New York Times database, there were headlines in the New York Times. And, there are obvious differences in the databases where CDC may have a lag and may be more accurate in the definitions of cases and in deduplication and things like that. So there are, of course, reasons for differences in numbers, but still notable in that the New York Times information was provided and is of interest. And they note that over 100,000 new cases are reported on November 4th, with an average of 91,878 per day over this time period, recently an increase of 51% from the average 2 weeks earlier. And now we are dealing with over 1,000 new deaths per day by either of these database reports, 1,095 per CDC on the day of November 3rd, and 1,616 reported per the New York Times. So concerning benchmarks to hit here nationally, of course. And this epidemic curve of the national picture shows just that. The blue bars are the cases, and then the red line is the 7-day moving average. So obviously of concern here nationally. We see where do we fit in here in New York on the CDC COVID data tracker, looking at case rates over the last 7 days. We see that we in New York are still in the lower numbers compared to our peers throughout the nation. There's a ranking by state or territory, and you can see here on the left are the highest rates states, North Dakota, South Dakota, etc. We see here on the right is the discontinuation of that as it would go off the slide, and these are the lowest rate states or territories. And we see here New York and rest of state and New York City are listed separately here on the CDC webpage at about 10 and 11 cases per 100,000, with the only areas or regions lower in the U.S. being Washington, California, Maine, Hawaii, and Vermont, as well as some of the island territories. And here on the Hopkins Coronavirus Resource Center, we see with percent positivity, again, all of these states that are in the yellow color to the right of the line, 37 states have higher than recommended percent positivities, some much higher, of course, with positivity rates above 5%. States on the left in green being states with positivity equal or below 5%. And we see that New York is really, at the lower end of the spectrum here nationally, thankfully. But now we'll look through the New York State numbers, and we have seen upticks, and this is something that we do absolutely need to continue to double down on and work on and educate our communities and our patients about these concerning trends. A positive benchmark, a good benchmark here, as we see on the upper left of this slide, that over 15 million COVID tests have been performed on New Yorkers. So that was a great benchmark to hit, with a whopping 133,500 plus tested on November 3rd alone. So these are good signs here, with availability and access to testing continuing to be improved every week. Unfortunately, we've had a total instances of individuals testing positive at over 500,000, with new positives on November 3rd of 2,126 on November 3rd alone. And remember, when we were doing these webinars, we would state we had numbers in about 500 to 600 to 700 range daily positives at our lowest point in the summer. So this is of concern. And this visual still does a nice job of portraying the really high levels of access to testing that are going on in New York State and the low relative rates of positivity, which is reassuring, but you can see a little bit of an uptick there as we get closer in the recent weeks. The current positivity rate from that date of 11/3 was 1.6% statewide. And note that's actually a stable number from 2 weeks ago when I last presented to you all. So we are holding steady on our percent positivity. Unfortunately, fatalities have increased some at 25,868. And in these dashboards, it's a slightly different dashboard, but the link is available at the bottom. These are available by region or by county. You can then look at your percent positivity over time. And again, we've been able to maintain high levels of availability, increasingly, and low rates of positivity over time. And here we see by region, just to give folks a sense, the total persons tested, those positive and percent positivity, either a 7-day average or yesterday. And you can see here looking at yesterday, and these fluctuate by day, which is why the 7-day average is available. But in Western New York, 3.4%, 1.9% in the North Country, 2.5% in the Mid-Hudson region, 2.9% in the Finger Lakes, 2.7% in Central New York. These are areas of concern. Of course, these can fluctuate on a daily basis, so important to look on the right at that percent positivity 7-day average, and where you'll see it's a little bit more smoothed out, but we still see concerns of 2.2% in the Finger Lakes, 2.2% in the Mid-Hudson region, and 2.6% in Western New York. And for healthcare utilization, as mentioned on our last webinar, we have unfortunately seen increases in COVID-associated hospitalizations, ICU admissions, and intubation numbers. We've also seen a slight uptick in deaths, but the numbers are small, so no obvious or clear trend, but clearly that is of concern to monitor and make every effort to educate our communities about prevention, as we expect that if hospitalizations, ICU, and intubations increase, that the number of deaths will follow. So we'll look at the currently hospitalized. We have 1,253, increased by 26, unfortunately. And again, if you recall, we had numbers in the 600 range here when we were presenting over the summer. Current ICU at 284, increased by 16. Current intubations at 129, increased by 9. That had gone down to the 60s range. Cumulative discharges, of course, continue to increase at over 80,000, showing the enormous effort and work here performed by all of our amazing healthcare workers in the field and working at hospitals, and all of you. Deaths, unfortunately, had previously been in the 5 to 10 range on a daily basis, and now we're looking at here 14, so that's a concerning uptick. So now let's go through some important updates for you all as providers. You may get questions from your community members on strategies introduced by the state. And so here are some important updates on community mitigation strategies. We've showed you the percent positivity being flat, but as noted, there's a lot more availability of testing and testing strategies that might test at low-risk individuals. And so we can't just look at, of course, the percent positivity. We really need to look at the number of new cases per 100,000. Here it's shared on our early warning monitoring dashboard as a 7-day rolling average, and you can look at this by region. Here, this is shown as a statewide. And again, the new infections per new cases per 100,000. So we see here that at our lower point in the summer, we were down to around the 3 per 100,000 range. And now most recently, we've jumped up to the 11 range here on the right. At our highest points earlier on an outbreak, we were up near 50. Although remember, early on, testing was more limited and more limited to ill persons who were hospitalized. Certainly less asymptomatic persons were tested. So certainly there are estimates that our true number of infections was likely quite significantly higher. Some say 4 to 7 times or more higher than what we have here on this curve of known tested and known and reported cases earlier on. But still, of course, we need to be concerned about this uptake and double down on our efforts for community mitigation, encouraging community members to mask and social distance where feasible. And now looking at the daily hospitalization summary, just so that you can see that this uptick mentioned on the prior slide, here's an example of that in graphic form, and that is available for you by region. When you look by region, you do see upticks. Please note that the axes are different scales, but you do see upticks in the capital region, in the central region, in the Mid-Hudson region, and so that is something to note as a provider to be aware of what's going on in your community. So now let's go through some updates with the New York State Cluster Action Initiative, or the microcluster strategy. Some new updates that have occurred since our last webinar. First, I would like to mention, I can't recall if we discussed this at the last webinar, that there is now a tool available on the webpage where individuals can find whether they're in a hotspot zone by address. Obviously, it can get complicated. There are maps on the webpage as well at this link at the bottom of the page. However, it can be difficult to tell where your house fits on that, or where your school or where your business fits. And so there is a nice and easy lookup tool on the website that you can use. So I wanted folks to be aware of that. We see here on the left part of the slide, the red, look at the top of this chart, and here's a simplified chart on the Cluster Action Initiative. We see red, orange, and yellow zones. So the red being these clusters that have met metrics, and those metrics are available with the link at the bottom of this slide, but it's based on population density and then metrics based on COVID numbers in these areas. It's a bit detailed and complicated, so I didn't put it all on the slide, but it's available for those who are interested with this link. And here we see in summary form the specific restrictions for the red, orange, and yellow zones. So in the red zones, non-essential gatherings are prohibited, versus in the orange, 10 people maximum indoors and outdoors, versus in the yellow is a 25 people maximum indoors and outdoors. For houses of worship, the lesser of in the red zone, 25% of the maximum capacity or 10 people. Lesser of for orange zone is 33% or 25, and the yellow zones is 50% capacity. For businesses, the red zones, non-essential businesses are closed. The orange zones, certain high-risk non-essential businesses are closed, such as gyms and fitness centers, barbershops, hair salons, personal care services. And then in the yellow, those businesses are open. Dining in the red zone is takeout or delivery only. Orange zone is outdoor dining, takeout or delivery. And then 4-person maximum per table. And then the yellow is indoor and outdoor dining permitted with the 4-person maximum per table. And then for schools, red and orange zones are initially closed for 14 days, remote only. We'll get more into after that 14-day period, and some new options for testing strategies to get back into in-person learning in a minute. Yellow, schools may be open, but there are mandatory weekly testing requirements for students and school personnel. And those were previously shared, but essentially 20% of that school population of teachers, staff, and students be tested on a weekly basis. These are very reminiscent, as folks are aware, of the phases we had of opening in New York State by region. However, here, this is really intended to, as we move forward, allow us in New York State to maximally maintain an open economy as much as possible and open structures and communities, while also focusing on areas where we're seeing hotspots or clusters and kind of zoning in on those. To give you some of the numbers, looking at the clusters, the positivity rate, percent positivity rate in the microcluster areas, they are throughout the state, Chemung County, Steuben, Brooklyn, Queens, etc. So these are not specific to only urban or rural settings. We see that if you combine all of these cluster areas, that those percent positivity rates are at about 2.7% yesterday. The range of them varies, and it changes by day, and so really 7-day trends are being looked at. But looking at November 3rd, ranging from 0.88% to 4.5%. So it really depends on the zone. And then if you look at the statewide positivity rate, which I told you was 1.6%, if you exclude those areas, it's 1.4%, just to give folks a sense of what that looks like. Some of the limitations in regard to residential congregate facilities, we've had several questions that have come into us about some recent guidance in this realm, so I wanted to run through this. The guidance document is available with the link at the bottom of this slide on residential congregate facility visitation guidance for red and orange zones. For the purposes of this guidance, what residential congregate facilities would include, and this is essentially, nursing homes, adult care facilities, pediatric and adult nursing homes, facilities where individuals with developmental disabilities are living in a group home, for instance, facilities where individuals affected by substance use are living, facilities for those receiving mental health services for group homes, other residential treatment centers, juvenile justice facilities, correctional facilities, and hospitals. So in the red zones, all visitation is suspended except for the instances where there is a compassionate care issue, where it's medically or clinically necessary. So the visitor is essential for the care of the patient, or those who are accompanying a minor, or during labor and delivery or postpartum care, or necessary legal representatives. Other essential companions for those with intellectual or other developmental disabilities or cognitive impairments, including dementia. The orange zones, visitation shall be suspended in an orange zone if any staff members or residents in that facility has tested positive for COVID in the last 14 days. And then the exceptions again for all of the above situations. Now looking at schools. Since our last webinar, the red and orange zone schools had initially been closed for in-person instruction and been using remote means for instruction. However, some guidance has been provided within the Cluster Action Initiative to allow schools in red and orange zones to reopen with a testing strategy to maintain the safety of all of those in the school, students, staff, and teachers. So this really offers an option. It's not required because schools can certainly go ahead and continue remote learning while they're in the red or orange zone if that is preferred. However, if schools in the red or orange zone would like to reopen with in-person instruction, this is the option to be able to maintain a safe reopening opportunity. So first, though, the schools must remain closed for at least 4 calendar days after that red or orange zone designation is announced, and then may reopen as early as the 5th calendar day after that designation was made, using the following criteria: that every person, student, staff, or teacher who attends in-person instruction or learning on the building or campus where the school is located must first receive a negative test result. And again, this applies to all teachers, staff, and students. Additionally, that result, that test, has to be obtained after the time of the zone designation and within the 7-day period prior to reopening. And that's only to say it obviously must be done recently, and you can't use a test result from a month ago to validate that safe reopening process. You can see a screenshot on the left of the guidance document here, and the link at the bottom is where you can then get to that guidance document for more of those details. After a school reopens in a red and or orange microcluster zone, of course, all of the already existing safety measures that all of the schools have worked so hard on must be maintained, and even more meticulous attention paid to them with daily symptom screening of students and staff, daily exposure screening. Have you been around anyone who had COVID? Every day of students and staff. All of the safety measures with social distancing, masking, cleaning, and disinfection. And then also they must follow the below guidelines after reopening. Each week of reopening while the school is still designated in the red or orange zone, 25% of the school population must be tested. And each week, of course, must be composed of unique individuals not tested the prior week. So, of course, you can't take the same cohort of people and test them every week. You have to get you different groups of individuals with each of the week's testing. Of course, do the math. If the red or orange zone is ongoing for where that school is located for more than 5 weeks, upon the 5th week, that individuals being tested will return to that first cohort of that 25% of the school on-site population who was tested initially. As an additional safety measure of this random sample of 25% generates 9 or more positive cases, or for those who are larger schools with a sample size of 300 on the weekly tests, that 25% is 300 or more if there's a positivity rate of 2% or higher in New York City, or 3% or higher outside of New York City on any one of those weekly testing events or compilation of test results. Then the school will be required to use remote learning and to close in-person instruction for that time being, and engage with their local public health and state public health partners to establish how and when to reopen. Many schools have questions about how to get this testing done, and that's why I wanted to present to you all today as healthcare providers, as this is critical that we all work together. We know this is an incredible challenge and burden on schools, and they don't usually do this. And so we know that we all must partner here at the state health department, local health departments, and community healthcare providers in partnership with schools to make this happen locally. So to ensure that students, faculty, and staff have been tested for COVID-19, schools have a number of options. They can accept written test results from healthcare providers. So individual students can go to their individual healthcare providers to have testing performed. They can also go to test sites that are New York State run or sponsored and have specimens collected there and get the results there. They can establish partnerships with other entities authorized to perform testing in their communities, other healthcare providers, or other entities like local health departments or other. And also, it's notable that schools can do testing on their own, meaning with their nursing or school-based health center. If they currently have a limited service lab registration, then they can add COVID rapid testing to their existing registration and request to receive the rapid tests from the state health department at no cost, and then perform testing for their students, faculty, or staff. Or they can become approved if they don't already have it to perform testing by obtaining a limited service lab registration. And once that approval is granted, then they can receive the test from the state and perform testing. And there's an email inbox here that you can email for any questions in that regard if you are a provider who might be a medical director or a physician, a school physician supporting schools in these efforts. For further commentary on testing, New York State will provide the rapid test kits upon request. But of course, the school must have someone who is a trained personnel with the necessary lab permit to conduct the test. And then all of the results must be entered in the electronic clinical lab reporting system known as ECLAIRS, the New York State lab reporting system. And also schools have to report through their school survey. So the provider doing the test needs to report the test results within 24 hours. And then also the school is reporting on their school population through the New York State COVID school report card. Consistent with existing requirements, any testing conducting through schools must be reported, including all of the rapid point of care testing. Now we have some updates on travel advisory updates. I know Dr. Friedrich will also be speaking to some of these in a moment, but I did want to cover some things as just this morning I had questions coming into me from some of our excellent local health department and healthcare provider partners. And so I wanted to try as best as possible to answer some of these questions and provide some clarity for all of you in the field. So firstly, this new travel advisory guidance from the state updates previously issued guidance from October 8th and earlier for travelers arriving from out of state. This replaces that guidance. And this travel advisory is for anyone coming to New York after travel to states that are not contiguous to New York or any CDC level 2 or level 3 travel health notice country. And again, it was a little bit, there was some confusion about whether the international travel was included prior to this guidance document coming out on November 3rd, so just a couple days ago. So I did want to provide the link for this guidance document so you have this in written form to refer back to, as well as clarify that the international travel from level 2 or 3 is included and from states that are not contiguous to New York State. Regardless of whether a state is contiguous or not, or an international travel country, any of that, all non-essential travel continues to be strongly discouraged as we aim to keep our rates as low as possible here in New York State. Any travelers from non-contiguous states or CDC level 2 or 3 travel health notice countries should, as previously discussed, quarantine for a period of 14 days after arrival in New York State. However, there is a new option if individuals would prefer, instead of quarantining for 14 days, to do a, quote, test out or an opt out or testing out strategy. So either if they don't want the testing, so be it, they quarantine for 14 days after arrival in New York State, or they can go ahead and do this strategy. To review what this is, for travelers who have traveled outside of New York for more than 24 hours, then those travelers must obtain testing from that location where they are in a non-contiguous state or in another country that's within 72 hours prior to leaving that location and coming to New York State. And upon arrival to New York State, they must quarantine for a minimum of 3 days. Then on that fourth day, it's really a minimum of 4 days, they will still be quarantined on that fourth day. They will then seek, in a safe manner, diagnostic testing. And we will stay quarantined until that result is back. And then if that is negative, they can get out of that quarantine with those 2 negative test results. So for travelers that meet the criteria above, they may exit quarantine upon receipt of the second negative test result. For some individuals getting a rapid test, that might be on day 4. when they get that test right away. For other individuals who are doing maybe a lab-based molecular test, and it might take a day or two, then they'll be in quarantine until that result is back on day 5 or 6 after return to New York State. And then when that comes back negative, that's their second negative test after the first one in, say, another state, and then this one in New York State, and then they would no longer need to be under quarantine. I'm going to state the obvious here for those of us who might be geographically challenged and just state what the contiguous states are: Pennsylvania, New Jersey, Connecticut, Massachusetts, and Vermont. Travelers from these states are not subject to this guidance. Again, as previously mentioned in previous webinars, we really encourage people to avoid non-essential travel even with these contiguous states. But because of the very frequent cross-state travel, it's felt that this isn't really feasible to implement with the contiguous states, so it's not required. So travelers who leave New York State for less than 24 hours do not need that diagnostic test in that 72 hours prior to departing. Obviously, that doesn't make sense, so they do not need that. However, they do need to test on the 4th day after arrival in New York, but they do not need to quarantine upon return when it's only that less than 24-hour period that they're out of New York State. So they must, though, fill out the traveler form upon entry like everyone else on travel and obtain a diagnostic test on the 4th day after arrival. All of these rules apply whether or not an individual is a New York State resident or an out-of-state resident. And all traveling to New York State from non-contiguous states or level 2 or level 3 countries must fill out that traveler health form on our webpage and share it on previous slides. I don't have it here yet. Sorry about that. And note, please let folks know that there can be penalties imposed. So that's important to educate folks on that. Now for essential workers. Exceptions are permitted for essential workers coming from a non-contiguous state or level 2 or 3 country. So the short-term workers and medium-term workers, that's going to be the same as prior guidance, that they must avoid public places, monitor themselves, social distance, wear masks, but they don't need any of this testing on return. However, the longer-term essential workers who are coming in greater than 36 hours, those essential workers must seek diagnostic testing on day 4 after arriving. Please note, this does not apply to those who are exposed to a person with COVID. They must still quarantine for 14 days. This is only for essential workers or others who are traveling here. Also note, this does not apply for teachers, school employees, and childcare workers. Although these workers are considered essential and on some lists as essential due to the nature of their work and the priority for testing, the travel advisory exempts them in this manner from they're not an essential worker in this regard, and they must quarantine for that time period, that minimum of 3 to 4 days before getting that 4th day test, quarantining in the community and not going to work. And then they get that test on the 4th day, whereas other essential workers are going to work in that 4-day time period, but quarantining in the community. The teachers, childcare workers, school employees are not going to school during that time. Please note, if you have a healthcare procedure or appointment scheduled in New York that cannot be postponed, you may travel to the extent necessary or your support person to maintain that appointment, but otherwise remain quarantined at the community level. Quickly, some FAQs that we've had about these that folks are really looking for answers on. So thank you for submitting these questions. Does the essential worker test at day 4? Because the prior guidance had essential workers testing within 24 hours of arrival. Yes, you are correct. They test at day 4 after return to New York State. They no longer need to do the test at 24 hours, although some industries or employers or hospitals or other medical settings may still prefer to do so. Is the essential worker allowed to work during the days of quarantine before the day 4 test is resulted in negative? Yes, the essential worker can work during that time frame along with all of the other pre-existing safety measures with monitoring every 12 hours and masks and PPE and social distancing. But when they're not working, they must quarantine in the community until that day 4 test is resulted and is negative. Is the essential worker expected to quarantine outside of work for the remaining days until day 14 as in prior guidance? And no, they may sort of test out of their community quarantine with that day 4 test. After arrival in New York State, once that's negative, then they can test out of that community quarantine as well. There has been confusion about whether the international level 2, level 3 countries are part of this test out option, and the answer is yes. They are, similar to the non-contiguous state travelers. And a common question we received is, can someone test out of quarantine after exposure to a known COVID case? Whether essential worker or not, no. This is a higher risk situation. They can be tested, of course, and we recommend testing after exposure to a known case, but they does not affect their quarantine. They must still quarantine for 14 days after last exposure, regardless of if they get a negative test result, as this is a higher risk scenario. And for essential workers in that category, after a known exposure or a breach in PPE and a healthcare worker exposure, they must follow all of the previous guidance about returning to work as applicable. Just a reminder about seasonal celebrations coming up. The CDC has put out some guidance on holiday celebrations. I've shared this with you previously, but important to start talking to your patients and community members about these issues. And the links are at the bottom of the page here, because we know this is a common concern for our community members and patients right now. And general guidance to have them think about is their risk level, their community levels of COVID where they are, and where their other friends or family are that they would potentially gather with. The location of the gathering, can it be outdoor or indoor? The duration, the number of people at the gathering, the location and where they're traveling from, and the behaviors of these individuals. And it's really important to get folks thinking about risk mitigation and a risk-benefit discussion, and other ways to celebrate that can be meaningful and yet safe. And we'll have more guidance on that from the state coming soon to this website. Dr. Friedrich will speak further about the COVID vaccine, but just to add a couple points here, again, it's good to start talking with our patients and community members about the fact that we absolutely will not want to go ahead with any rollout of vaccine unless this vaccine is deemed to have a favorable risk-benefit profile. Although there, even in the early days, will be a lot that we remain to know about the vaccine, we still must have first, comfort with the risk-benefit safety profile. There are many national organizations and independent organizations, as well as here at our state, who will ensure that we will review all of this data as much as possible, and moving forward, be open and transparent with our patients and community members about what we don't know moving forward about the vaccine and the risk benefit and safety profiles moving forward. We know that phase 3 are completed for at least 2 of our front-runner vaccines, Moderna and Pfizer, have completed enrollment. And now we need to wait for the individuals in the vaccine arm and in the placebo arm, and wait for a significant number of events or COVID infections so that we can establish the number occurring in those vaccinated and not vaccinated. And also for the FDA EUA, experts have really insisted we have at least 2 months of safety data before it even be evaluated for an FDA emergency use authorization. And so most folks think it will be at best around December before these may be submitted, just to give you a general timeline plus or minus, with some then considerations and rollout if things go well with the vaccine in the new year. But remember to please get yourself set up in NICIS for those practices outside of New York City, and CIR for those in New York City. Here is the email inbox to email to do so that you can be ready to vaccinate high-risk adults. Our initial rollout will be among healthcare workers. In the U.S., about the first 20 million will be among healthcare workers, and a lot of that will occur through hospitals. And that's a well-established mechanism. And the cold chain can be maintained in the logistics of that distribution system. But the next 100 million nationally will be very logistically challenging and will include high-risk groups with providers providing to individuals who are older or have comorbidities, and will require everyone to get ready for this. And we'll do more and further webinars on the specifics here. Really quickly, preventing the spread of SARS-CoV-2 with masks and other low-tech interventions. This was written by 3 folks from the NIAID, including Dr. Fauci. And I think it's important to, even when we talk with our patients and community members about vaccine, to emphasize that while results of phase 3 trials for multiple candidates are on the near horizon, low-tech tools to prevent the spread of SARS-CoV are still essential. It must be emphasized that these interventions will even be needed even after a vaccine is initially available, given the limited initial rollout, given potential limitations to its efficacy. Absolutely, we still need to use masking and social distancing and hand washing and some of these basics that are core public health measures that we as providers need to continue to educate our communities about. I'd like to mention a webinar that's going to be available from MISNI, the MISNI Medical Matters webinar series about COVID stories from the front line by Dr. Eiting, an emergency department physician at Mount Sinai downtown, who will share his experience from the first days of the COVID pandemic. As we have upticks, we want everyone to learn from our lessons learned, and he is certainly able to speak to that. Here is the registration link on the slide. It's going to be Wednesday, November 18th at 7:30 a.m., and then available as an archived webinar thereafter. And now we'll hear further from Dr. Marcus Friedrich.
Thanks, Liz. Hi, everybody, and welcome, and thank you for joining this afternoon. I wanted to take a moment and talk about three specific items. One is the travel advisory that just came out this week. The second is the COVID test result reporting, and the third is give you more information on the vaccine. So the travel advisory was updated on November 3rd with an interim guidance update where the commissioner and also the governor strongly discouraged all non-essential travel across state lines. One of the stipulations was that everybody who is coming in from out of state has to be 14 days on quarantine. But there is a new ad, and that is something that I want to just mention here, that you can get off the 14-day quarantine if you had a COVID test up to 3 days prior coming to New York, and if you then quarantine for 3 days minimum and get another day on the fourth day, another test that would be presumably negative. You have to wait for the receipt of the test, and then you can exit the quarantine. This is in place for all travel from outside the state, but does not include the states that are bordering New York, such as Pennsylvania, New Jersey, Connecticut, Massachusetts, and Vermont. And then if you're less than 24 hours away from New York, you do not get a test before departure or no quarantine, but when you come back you need to get a diagnostic test on day 4. And again, this is laid out in the November 3rd interim guidance on the update on the travel advisory, and it is also on our provider compilation that can be found on the New York State Department of Health COVID-19 provider webpage. Every traveler has to fill out a health form, and again, quarantine for patients that we might see means that they need to have separate quarters, they need to have separate food, and then a system for symptom check going forward. There is also, again, and I just want to mention it here, and you can read up on that, the stipulation about essential workers. And that is broken up into like 3 different time frames. If you travel from outside New York to New York and you're in New York only less than 12 hours, you need to avoid extended contact and stay in your vehicle and limit the exposure. If you come from outside New York to New York and be here only less than 36 hours, you need to avoid contact. And then if you come from outside New York to New York and you are longer than 36 hours, again, you need that diagnostic COVID test at day 4. There is also, when we talk about essential workers, returning to work guidance, and I will just direct you again to the documents that you can find on the website. And then there is also a medical appointment guidance that we put out on June 28th, and again the link can be found on our provider compilation that can be found on the DOH website. And again, if the whole point is, if you have an appointment, a medical appointment, and traveling from outside New York to New York, and you have to wait longer than 5 days, you need to seek testing up on arrival. And if it's less than 5 days, you do not need to seek testing. You can come in, you need to stay in quarantine until the appointment, and then after the appointment, and then leave the state after the appointment. The second topic that I want to talk about is the COVID test result reporting to the electronic clinical lab reporting system, or eClaris. As you know, there was this rule that every provider has to report into the system test results in 3 hours. That was changed with the executive order that came out this week, Executive Order 202.72. That addresses clinical labs, licensed professionals to report the results within 24 hours. So it was expanded, that window. Just an important point. And then last but not least, about the vaccines, there is, as you know, this Advisory Committee for Immunization Practices, or ACIP. What I didn't know is that the ACIP meetings are webcasted live, and you can go on the CDC website and look for the link. And again, how the vaccines are approved, that the FDA would get an application from the manufacturer and then authorize or emergency use approve the vaccine. And then the ACIP, the Advisory Committee on Immunization Practices, will hold a meeting to review the data that is presented to the FDA, and then take a vote and recommend either the vaccine or do not recommend, and also recommend who should receive it if the supply is limited. After that, there is a small step that I was not aware of, that the CDC director has to approve and make it then official policy. And then after that, as you know, we have here in New York the Clinical Advisory Task Force in place to help really determine if the vaccine is safe and effective, and advise New York State to distribute the vaccine or not. And again, that is also going to be a public meeting, and hopefully there will be then, and it's not scheduled, of course, because we don't know when the vaccines will be approved or not. We will make then the link publicly available. So that is it for my update. Thank you very much, and back to you, Liz.
Thank you, Dr. Friedrich. While Dr. Friedrich and I are not working together today, we are COVID safe and quite socially distanced, but that required us to record and merge our presentations. And while he was recording his, I did receive many questions from a number of you who I know well and are working so hard in the field, many questions on the travel advisory. So I really, even though I knew he was covering that, I really wanted to give you all specific answers to some of your questions. Just a reminder about the COVID Alert New York app. You know, the more people that use it, you really need a group of folks, a large percentage of the population at least using it for it to be of any value. So a reminder there. And then we have our other resources here that are always here on healthcare provider wellness, our healthcare provider compilation, which Dr. Friedrich mentioned is a good place where you can find all of these advisories, because it can be challenging to find on the webpage, which can be overwhelming with all of the resources there. Again, we need to go back to the basics always of our community mitigation efforts with masking and washing your hands. So here's a nice tool with washing your hands. As far as masking, there have been some mask up campaigns that have been shared even nationally. And so go ahead and check those out on YouTube. Share those if you're on social media. This is really going to be the name of the game as we enter this and continue in our fall season. As our in New York weather becomes colder and folks are indoors more, we really need to emphasize always wearing a mask, wearing it properly, wear it when you're talking, don't take it off when you're talking, and all of these other measures. A thank you for joining us today, and a thank you for all of the work you're doing. All of this year, this entire year has been really challenging for everybody, and we really appreciate your collaboration and all of the amazing work that you do for all of your patients and your communities, and your patients and your practices. Thank you very much.